Welcome to British BioMedicine Institute. Today Dr. Pramod Khatri, is going to represent a simple topic named as inflammation. So inflammation is basically a non-specific localized immune reaction of the organism which tries to localize the pathogen agent. Many consider the syndrome as self-defense mechanism. It consists of vascular, metabolic, cellular changes triggered by entering a pathogen agent in healthy body. Etiology. The cause of inflammation are many and it varies. It can be due to exogenous causes like your physical agent, which includes your mechanic agent like fracture, foreign corpse, sand, etc. Thermal agents like your freezing or burning. Chemical agents like toxic gas, acid and base. Biological agents like your bacteria, virus and parasite. Whereas endogenous cause can be due to circulation disorders like your thrombosis, infarction, hemorrhages. Enzyme activation can be due to active pancreatitis and metabolic product disposal like your uric acid or urea. So the cardinal signs are Calces describe the local reaction of injury in terms that have come to be known as cardinal sign of inflammation, and these are rubor, redness, tumor swelling, calor, heat, dolor, pain, and functio lisa or loss of function. In the 2nd century AD, the Greek physician Galen added this 5th cardinal sign, inflammation. Basically, the inflammation reaction takes place at micro-circulation level and it is composed of following changes like your tissue damage, cellular vascular response, metabolic change or tissue repair. Tissue damage. The change begin mostly after the injury because the pathogen agent action in the infected tissue are released. Mediated response for the following event of inflammation: tissue macrophage, monocytes, mast cell, platelets and endothelial cells are able to produce multitude of cytokines. The cytokines like your TNF, tissue necrosis factor A or interleukin IL-1 are released first and they initiate several cascades of reaction. Inflammatory mediators like your TNF-A or IL-1 are responsible for fever and release of stress hormones like norepinephrine, vasopressin, activation of renin-angiotensin, aldosterone systems. TNF-A and IL-1 are responsible for synthesis of IL-6, IL-8 and interferon gamma. Cytokines, especially IL-6, stimulate the release of acute phase reactant such as CRP, C-reactive protein. Pro-inflammatory interleukins either function directly on tissue or work via secondary mediator to activate coagulation cascades, complement cascades and release of nitric oxide, platelet activating factors, prostaglandins and leukotrienes. Complement fragments and cytokines which helps in stimulation of chemotaxis of neutrophils, eosinophils and monocytes. They also activate C3A, C5A in order to increase the vascular permeability. Cytokines, they produce interleukins IL-1, IL-6, IL-8. They stimulate chemotaxis, degranulation of neutrophils and their phagocytic activity. And they also induce extravascularization of granulocyte and they can also lead to fever. And activation of TNF, tumor necrotic factor or IL-8, which can result in activation of leukocytosis, fever, and they also stimulate prostaglandin production. Prostaglandin also play an important role. The prostaglandin are ubiquitous. They are lipid soluble molecules which are derived from arachidonic acid. Basically, it is a fatty acid which has been liberated from cell membrane, phospholipid and through COX pathway, cyclooxygenase pathway. Prostaglandin contribute to vasodilation capillary permeability, and pain and fever that accompany inflammation. The stable prostaglandin PGE1 and PGE2 induce inflammation and potentiate the effect of histamines and other inflammatory mediators. They cause the dilation of precapillary arterioles like edema. They lower the blood pressure, modulate receptors activity, and they can affect the phagocytic activity of leukocytes. The prostaglandin thromboxane A2 can promote platelet aggregation and vasoconstriction. Now comes leukotriene. Leukotriene are basically formed from arachidonic acid but through lipoxygenase pathway. Histamine and leukotriene are complementary in action in that because they have a similar function. Histamine is produced rapidly and transiently while the more potent leukotriene are being synthesized. Leukotriene like C4 and D4 are recognized as the primary component of slow reacting substance of anaphylaxis SRSA that cause slow and sustained constriction of bronchioles. Leukotriene also have been reported to affect the permeability of post-capillary venules, the adhesion property of endothelial cells, and they stimulate chemotaxis and extravascularization of neutrophils, eosinophils, and monocytes. So this is the COX and lipoxygenase pathway. There will be disturbance in the cell membrane, and your membrane get phospholipid and arachidonic acid will be released, which can lead to two pathways. First one can be a lipoxygenase pathway, which can lead to a production of leukotrienes, and another pathway will be COX and cyclooxygenase pathway, which can lead to activation of prostaglandin. Now comes histamine. Histamine basically is an inflammatory mediator. It is found in high concentration in platelet, basophils, and mast cell. It can cause dilation and increase the permeability of capillaries. It causes dilation of precapillary arterioles, contraction of endothelial cells, and dilation of post-capillary venules. It basically acts through H1 receptor. Now comes PAF, platelet activating factor. It is generated from a lipid complex which has been stored in the cell membrane. It affects a variety of cell types and it can induce platelet aggregation. It activates neutrophils and it is a potent eosinophil chemoattractant. It contributes to extravascularization of plasma protein and so-called edema. Plasma protease. The plasma protease basically consists of kinin and clotting factors. Kinin consists of bradykinin, which cause increased capillary permeability, which can be implicated in hypothermia and redness, or it can lead to pain. Clotting factor. Clotting factor contributes to vascular phase of inflammation, mainly through fibrin peptides that are formed during the final step of clotting processes. Now comes vascular response. In phase 1, there will be a vasoconstriction. Basically, it is a momentary constriction of small blood vessels in the area. Vascular spasm begin very quickly within 30 seconds after the injury, and it lasts in few minutes. The mechanism of spasm is nervous. It will be through catecholamine liberated into the sympathetic nerve endings. Phase 2. It can lead to active vasodilation. Basically, it will be through catabolism product that act through receptors and directly stimulate vascular dilation. Again, it is a nervous mechanism. And there will be dilation of arterioles and capillaries, redness, or we can say rubor. Blood flow increase and it will give a pulse sensation. And there will be an active hyperemia in skin territory, and it will increase metabolism, which lead to higher local temperature like heat, or we can say calor. Phase 3, there will be production of passive vasodilation. Basically, blood vessels in the affected area, they lose their reactivity to nervous and humoral stimuli, and positive vasodilation can occur. Progressively, fluid move into the tissue. It will increase vascular permeability and structural alteration of blood vessels and cause swelling like tumor or pain, and it can impair function. The exudation or movement of fluid out of the capillary and tissue space dilute the offending agent. As the fluid move out of the capillary, stagnation of flow and clotting of the blood in the small capillary occur in site of the injury. This aid in localizing the spread of infectious microorganisms if in the case. Now comes cellular response. The cellular response of acute inflammation is marked by movement of phagocytosis, WBC or leukocytes in the area of injury. Two types of leukocyte participate in acute inflammatory response like granulocyte and agranulocyte. The sequence of event in the cellular response of the inflammation will include your pavementing, immigration, chemotaxis and phagocytosis. Pavementing is basically a release of chemical mediator like your histamine, your leukotrienes and kinin, and cytokine affect the endothelial cells of the capillary and cause the leukocytes to increase their expression of adenosine molecule. As this occurs, the leukocytes slow their migration and begin to marginate and move to or along the periphery of blood vessels. Now comes immigration and chemotaxis. Immigration is basically a mechanism by which leukocytes, they extend pseudopodia, pass through the capillary wall by ambient movement and migrate to the tissue space. The immigration of leukocytes also may be accompanied by an escape of RBC cells. Once they have exited the capillary, the leukocyte move through the tissue guided by the secreted cytokines, either bacterial or cellular debris or C3A or C5A, which are basically a component fragments. The process by which the leukocytes migrate in response to a chemical signal are known as chemotaxis. Now comes phagocytosis. During the next and final stage of cellular response, neutrophils and macrophages engulf and degrade the bacteria and cellular debris in a process named as phagocytosis. Phagocytosis is basically involved in 3 steps. First one is your adherence plus opsonization. Second is your engulfment. And third is your intracellular killing through enzymes, toxic oxygen or nitrogenous product produced by the oxygen dependent metabolic pathway or nitric oxide like your peroxynitrite, hydrogen peroxide or hypochlorous acid. If the antigen is coated with antibodies or complement, its adherence is increased because of binding to the complement. The process of enhancing the binding of an antigen caused the antibody or complement is known as opsonization. So this is a diagram of phagocytosis where your foreign material are being engulfed by the process named as phagocytosis. Now comes the metabolic changes. Basically, there will be a protein metabolism which is increased, like if there is a cell destruction, metabolic product lead to increased osmotic pressure in interstitial space which attract water and contribute to edema. Edema is basically a swelling or tumor. The metabolic chains including your skeletal muscle catabolism provide amino acid which can be used in immune response or for tissue repair. There can be a glucose metabolism also, basically through anaerobic utilization of glucose is increased because the hypoxia with increased formation of lactic and pyruvic acid is there. It can also affect the lipid metabolism. There will be an increased formation of ketones and fatty acid. Mineral metabolism, increased extracellular potassium concentration, and acid-base balance, metabolic acidosis like your ketones and lactic acids, they can change. So basically inflammation can happen at 3 different stages: stage 1, stage 2 and stage 3. So in stage 1, following an insult, local cytokine is produced with the goal of inciting an inflammatory response, promoting wound repair, and recruitment of reticular endothelial system. Stage 2. Small quantity of local cytokines are released in the circulation to improve local response. This leads to growth factor stimulation and recruitment of macrophages and platelets. This acute phase response is typically well controlled by the decrease of pro-inflammatory mediators and by the release of endogenous antagonist. This is the main goal of homeostasis. Stage 3. If homeostasis is not restored, a significant systemic reaction can occur. The cytokine release lead to destruction rather than protection. A consequence of this is the activation of numerous humoral cascades and the activation of reticular endothelial systems and subsequent loss of circulatory integrity. This leads to organ dysfunction. So under systemic manifestation of inflammations, the inflammatory response remains confined to local area. In some cases, local injury can result in prominent systemic manifestation as inflammatory mediators are released in the circulation. The most prominent systemic manifestation of inflammations are acute phase response. Second, alteration of WBC cell count like your leukocytosis or leukopenia. Third is fever. And fourth is sepsis or septic shock, also known as systemic inflammatory response, which represent the severe systemic manifestation of the inflammation. Under acute phase response, it usually begins within the hour or days of onset of inflammation or infections, and it includes change in the concentration of plasma protein, particularly liver, dramatically increase. There will be synthesis of acute phase protein such as fibrinogen or C-reactive protein. There will be increased ESR, erythrocyte sedimentation rate, fever, increased number of leukocytes, skeletal muscle catabolism or negative nitrogen balance will be there in acute phase response. These responses are generated after the release of cytokine IL-1, IL-6 and TNF, tumor necrotic factor. These cytokines affect the thermoregulatory center in the hypothalamus to produce fever. IL-1 and other cytokines induce an increase in the number of immaturity of circulatory neutrophils by stimulating their production in the bone marrow. Lethargy. Basically, it is a common feature of acute phase response which result in effect of IL-1 and TNF of the CNS, central nervous system. Tissue repair. The primary objective of healing process is to fill the gap created by the tissue destruction and to restore the structural continuity of the injured part. This effect is known as restituo ad integrum. Concomitantly with tissue damage at the peripheral of the inflammatory process, begin the repair process in order to limit the extension of it. Reparatory process will help in cell proliferation. Conjunctive tissue proliferation will be there. Blood vessel neoinformation will be there, like your angiogenesis. Lymphatic drainage of exudates will be there, and phagocytosis. Injured tissue are repaired by regeneration of parenchymal cells or by connective tissue repair, in which scar tissue is substituted for parenchymal cells of the injured tissue, like this could lead to malfunction of organ or fibrosis. The chemical mediator and the growth factor, they can also help in healing process. Some growth factors like your chemoattractant, they can enhance the migration of WBC cells and fibroblasts at the wound site. Other act as mitogens, causing increased proliferation of cells that participate in a healing process, like your platelet-derived growth factor, which is released from activated platelets, and they attract WBC cells and act as a growth factor for blood vessels or fibroblast. Many of the cytokines discussed function as a growth factor that are involved in wound healing. Tissue repair. Fibroblast and vascular endothelial cell begin proliferating to form a specialized type of soft pink granular tissue known as granulation tissue. This tissue serves as the foundation for scar tissue development. It is fragile and bleed easily because of numerous newly developed capillaries. The newly formed blood vessels are leaky and it allows plasma proteins and WBC cells to leak in the tissue. At approximately the same time, epithelial cells at the margin of wound begin to regenerate and move toward the center of the wound, forming a new surface layer. As the proliferative phase progresses, there is a continued accumulation of collagen and proliferation of fibroblast. Collagen synthesis reaches a peak within 5 to 7 days and continues for several weeks, depending on wound size. By the second week, the WBC cells have largely left the area, the edema has diminished, and wound begins to blanch as the small blood vessels become thrombosed and degenerate. Malnutrition. So there are basically various factors which can affect your healing. First point is your malnutrition. Protein deficiency prolongs the inflammatory phase of healing and it can impair fibroblast proliferation, collagen or protein matrix synthesis, angiogenesis and wound remodeling. Carbohydrates are needed as an energy source for WBC cells. Fat are essential constituents of cell membrane and are needed for synthesis of new cells. Vitamin A, vitamin C have shown to play an important role in healing process. Vitamin C is needed for collagen synthesis, first point. Second point, vitamin A function in stimulating and supporting epithelialization, capillary formation and collagen synthesis. Vitamin B is important cofactor in the enzymatic reactions that contribute to wound healing process. Vitamin K play an important role in wound healing by preventing bleeding disorders. The another factor which can affect wound healing is blood flow and oxygen delivery. These are the pre-existing health problems. If there is an arterial disease or venous pathology, it can affect blood flow. Molecular oxygen is required for collagen synthesis. It has been shown that even a temporary lack of oxygen can result in formation of less stable collagen. Wound in ischemic tissue become infected more frequently. PMN and macrophages require oxygen for destruction of micro-organisms. Now comes the resolution of inflammation. Inflammation response must be actively terminated when no longer needed to prevent unnecessary bystander damage to the tissue. Failure to do so results in chronic inflammation or cellular destruction. Resolution to inflammation occurs by different mechanisms in different tissue. Mechanism which serve to terminate inflammation includes, first point, short half-life of the inflammatory mediator in vivo. Second point, production and release of TGF, transforming growth factor from macrophage. Third point, down regulation of anti-inflammatory molecules such as your interleukin-1 receptor antagonist and soluble tumor necrosis factor receptor. Next point, apoptosis of pro-inflammatory cells and IL-4 and IL-10 interleukin are cytokines which are responsible for decreasing the production of TNF-A, IL-1, IL-6 and IL-8. Production of anti-inflammatory lipoxin. Evidence now suggests that an active coordinated program of resolution can initiate in the first few hours, which after inflammatory response has begun. After entering tissue, granulocytes promote the switch of arachidonic acid, which is derived from prostaglandins and leukotrienes, to lipoxin, which initiate the termination sequence. Neutrophils recruitment that sees a programmed death like your apoptosis is engaged. These events coincide with the biosynthesis like your omega-3 polyunsaturated fatty acids for resolving or protecting, which critically shorten the period of neutrophils infiltration by initiating apoptosis. Consequently, apoptosis neutrophil undergo phagocytosis by macrophage, leading to neutrophil clearance and release of anti-inflammatory and reparative cytokines such as your TGF, transforming growth factor beta 1. The anti-inflammatory program ends with the departure of macrophage through lymphatics. Now comes outcome resolution. The complete restoration of inflamed tissue back to the normal status. Inflammatory measures such as vasodilators, chemical productions or leukocyte infiltration case, cease and damage parenchymal cell can regenerate. In situation where limited or short liver inflammation has occurred, this is usually the outcome. Fibrosis, large amount of tissue destruction or damage in tissue which is unable to regenerate. They cannot be regenerated completely by the body. Fibrous scarring occurs in this area of damage, forming a scar composed primarily of collagen. The scar will not contain any specialized structure such as your parenchymal cells. Hence, specialized functional impairment can occur. There can also be an abscess formation. The cavity is formed containing pus. Basically, it is an opaque fluid which contains dead WBC cells and bacteria with general debris from destroyed cell. And in the chronic inflammation, in an acute inflammation, if the injury agent persists, then chronic inflammation will ensue. The process marked by the inflammation lasts many days, months, or even years, and it may lead to formation of chronic wound. Chronic inflammation is characterized by dominating presence of macrophages in the injured tissue, but the toxin they release, including reactive oxygen species, are injurious to the organism own tissue as well as invading agents. Consequently, chronic inflammation is almost always accompanied by tissue destruction. So this is all about the presentation. I hope you have gained a lot of clinical information through this presentation. Please like, share, subscribe our YouTube channel named as British Biomedicine Institute. Good luck. Goodbye.